It is 10 times the size of Kericho County, 25 times the size of Kirinyaga, and more than 30 times the size of Nairobi County. We are speaking about county number 11, Isiolo County, geographically located right at the center of Kenya. Good evening, my name is Joe Agayo, and this is Monday Special Town Hall, coming to you live from here in Isiolo County, right here at the Apostolic Vicariate here in Isiolo. And in the next few minutes, we are going to be welcoming our guests here as we talk about universal healthcare. That one of the big four agenda items. And tonight we have our guests. First on stage, please help me to welcome Dr. Mohamed Kuti, who is the governor of Isiolo County. Next on stage is Eliud Murithi, who is the Commercial Director of the Kenya Medical Supplies Authority, KEMSA. Ladies and gentlemen, welcome on stage as well Valentine Nyagodhie, who is from the civil society movement, and she represents pastoralist gender initiatives. And last but not least, Dr. Hussein Abu Bakar, who is the Director of Health here in Isiolo County. Please help me to welcome him to the stage. Now, also with me in this presentation tonight is my colleague Mashirima Kapombe, who will be engaging the audience here to try and get perspectives from the mwananchi. Mashirima.
Na asante sana Joe Ageo, ukiwa tu unajaribu kuwakaribisha hata kwa makofi kutoka kwa wananchi wa Isiolo, wageni wetu ambao watakuwa wanajibu maswali ambayo yatatoka moja kwa moja kutoka kwa wananchi. Labda tu niweze kupata kauli ya moja kuhusiana na matarajio yake itakapofika mwisho wa kipindi hiki. Hebu tueleze tunatarajia ufahamu nini baada ya kipindi hiki?
At the end of the day, we want to understand more better about KEMSA, their role, and how they're going to partner and work with the county government for the interests of Isiolo people.
Ndio baadhi tu ama ni mojawapo tu ya kauli ambayo iliyo katika ukumbi huu. Kuna maswali mengi ambayo yameulizwa kuhusiana na majukumu ya KEMSA, lakini pia kuna jukumu la serikali ya kaunti ya Isiolo katika kuhakikisha kuwa ile ajenda ya serikali kuhusiana na kuwa kila Mkenya aweze kupata afya bora tena kwa kila mmoja wao itaweza kutekelezwa kwa njia gani. Na leo Joe, imekuwa siku ndefu kwangu.
Yes, without a doubt. And earlier on, my colleague Mashirima Kapombe, as she mentioned, was in different parts of this county trying to get a snapshot of what really happens here on the health front. Here's a look at what she prepared for us from out there.
A scenic ride across the county of Isiolo. The beauty that belies the challenging road to achieving universal health coverage for Kenya's 6th largest county. At Noloroi village, approximately 40 kilometers from Isiolo town, children are being immunized against polio. Health officers from the county travel from Manyata to Manyata.
Sheria ya polio lazima ufike nyumba kwa nyumba. Na sasa wale wanakuja kupeana hizo chanjo wanapitia tu kwa barabara, wanakuja tu na pikipiki yao wanapitia kwa barabara, wanapata tu watoto wadogo wanaingia kwa laga pale tunachukua maji, alafu wanapata tu watoto wanabebwa tu na mama zao, wanapatia tu alafu wanaenda.
Thomas explains immunization is not the only health service that they sometimes miss out on. Pregnant mothers bear the greatest brand of Isiolo's treacherous terrain.
Mama akijifungua ashinde kujifungua. Sasa ni mwenye hiyo mama tu ndio anatafuta njia ya hiyo mama apate kujifungua kwa health center, na atatumia pesa 2,000 kwenda mpaka kwa health center na 2,000 tena kurudisha mpaka kwa boma.
The nearest health center from Noloroi is Kipsing. Without a public transport system, the sick depend on the generosity of the local priests and the GSU. A journey that is slightly over 60 kilometers from Isiolo town ends here at Kipsing Health Center. Now, according to this map, this is where we are. Noloroi, which is where we spoke to Thomas Lesasuyan, is 20 kilometers away. Kipsing serves hard-to-reach areas such as Longaman, Lpuzi, Lemorijo, Longopito, amongst others. And as the health center seems like a welcome relief to the residents, transportation is a challenge. 2 ambulances from the county government, which should ease transportation of the sick and pregnant mothers from the villages, are grounded.
Moja ifanyi kazi, moja iliharibika kitambo sana. Sasa inasimama tu. Lakini ingine tuliletewa hata bado hajakaa mwezi mzima. Imeharibika pia.
Sasa hapa tuko na ambulance 2 iko kwa parking. Moja ilikuwa ya kitambo sana, karibu hata ijaye mwezi 7 ikiwa inalala hapo. Ingine imeletwa karibu mwezi moja iliyopita, na tena hiyo iko pia imeharibika, ndio hand pump pump yake ya mafuta haifanyi kazi. Kwa hivyo hapa iko shida kwa upande ya transportation.
The drugstore is fully stocked, but as the community health volunteer explains, this is not always the case.
Kwa mara nyingine tunakuanga na madawa, lakini kuna wakati mwingine hatukuangi na madawa. Na tunakaanga pia kwa muda kidogo bila kuwa na madawa. Alafu baada hata mwezi mmoja tunaweza kaa bila madawa saa zingine.
Initially we have been having issues with medical supplies because we had deaths with KEMSA, but now we cleared, and we are having very good relationship with now KEMSA in terms of medical supplies. We sat down with them. They have also trained people for us in terms of doing forecasting, and currently all our facilities, including the rural facilities. In fact, for this financial year, the first quarter, we got the supply. For the second quarter, we have already placed our orders, and it is on the way.
In hard times, residents say the sick have been forced to sell their livestock to access drugs from a local chemist at the Kipsing village center. Sometimes it is too little, too late for a patient once a buyer is found. Isiolo County has 1 level 4 hospital, 2 sub-district hospitals, and more than 50 smaller health facilities dotted across the county's 25,000 square kilometers. At the referral hospital, things are picking up. Jane Moronchia has had kidney trouble for the last 3 years. She can now get dialysis here without having to make the long journey to Nairobi. Most of the expenses around the treatment are now taken care of, but she says the ultimate treatment will be a kidney transplant, and for that, there is a problem.
Lakini ningeomba kama itawezekana wale patients ambao wanafanyiwa transplant, ambayo tunaambiwa na daktari it's the only way tunaweza saidiwa, kwa sababu hii shinda ya figo most of the times kama unafika mahali ambapo unaoshwa inakuwa chronic disease.
Isiolo is one of the 4 counties chosen by the national government to run universal health coverage on a pilot basis. And the lessons from here are expected to help in bridging the big gap that currently leaves out millions of Kenyans without treatment and without the money to pay for it. Mashirima Kapombe, Citizen TV, Isiolo.
All right, a small snapshot there from my colleague Mashirima Kapombe earlier in the day. Obviously, this is a big county and there are many, many aspects that probably are not captured there. But I'll start right now with the governor who's next to me, Daktari. Very interesting basic questions coming out of the story my colleague has done, where people are still talking about things like hakuna dawa. People say this issue of drugs not being there, they're there today, they're not there. From the perspective of the county government, what's that about?
Well, I think this is an evolving problem that we are trying to get over completely. In fact, maybe now they're talking about 1 month or so, but there are times in the past that things have been worse. But we have now, when we came in last year, we had the debt of over 53 million. And we had to order our own medicine when we arrived, of about 30 million or so. So we cleared all that 80-something million, and we have now improved our debt to current. In fact, as we are, we only have to pay what we have ordered. So we have current debt. We do not have any backlog in terms of payment. So in the past, it is these debts that make the delays in receiving the medicines. But also, there is, even if there's no debt, there is the synchronizing of the orders, where the rural health facilities make their orders. This is then put together by the county pharmacist, who then now makes one order for the county. Sometimes this synchronizing doesn't happen very efficiently. So you find the delay actually is maybe because of these orders that are being waited to be done together.
Now on the issue of debt, this seems to be a national problem. I mean, there are all kinds of stories we've had from different counties, and because you had the health docket in the Council of Governors, I hope you still do, you could surely speak to it, where several counties owe KEMSA some money, and yet this money is supposed to be a revolving fund that the moment counties pay, then it is what is then used to get additional drugs for the next phase or for the next county. What is the problem from where you stand? Why is it so difficult for counties to pay up?
Well, I think there are several factors, and to generalize, I think one is the inheritance of pending bills. You come, you have now, like I'm talking about in my case, you come and you find already you are in debt. So you have to service that previous debt and then pay for the current, which then puts you in a bit of tough situation because resources are limited. That's one. Number two is the flow of funds from Treasury to the counties. Sometimes the flow from Treasury to counties delays so much that although you are due to pay for your medicines, you can't because you haven't received your allocation from the National Treasury.
Okay.
So this delay then makes now, and then medicines have to be procured. So you have to now negotiate with KEMSA to supply. So this then overlaps your regularity and affects your ability to be regular in terms of paying.
And that's a good place to bring in KEMSA. And Bwana Morethi, there is the whole question of debt that the counties owe. The last I checked, it was almost 3 billion, 2.7, 2.8. How bad is this from the KEMSA standpoint, and what is the impact of that when counties don't pay?
Thank you, Joe. Just like you clearly stated that KEMSA does not rely on government funding, KEMSA relies on a revolving fund. We introduced a supermarket model in 2013 after devolution came into being, when counties were required to pool commodities as opposed to when we used to push commodities. Therefore, this postulated that KEMSA had to procure commodities, warehouse them, and distribute to its customers, the counties and the faith-based institutions, among other government agencies. So what this has done is that we are unable sometimes to procure commodities and distribute them to the counties because we rely on that money to pay for those commodities and also to pay for distribution costs. However, having said that, we also get some funds, fees for services from our development partners, because what we have done is to approach the development partners to use the national mechanism of supply chain of medical commodities managed by KEMSA, and they pay fees for the services. If a development partner tells us to procure, they'll pay 2% of the value of commodities for procurement, 5% for warehousing, 3% for warehousing, and 5% for distribution. That has really supported us to ensure we are able to service the counties. But I must admit that we have had very fruitful discussions with the Council of Governors and the respective county governors. And just like the governor of Isiolo has stated, is that yes, there were quite a number of pending bills from previous governments that dogged quite a bit of the procurement that the counties would have done at that particular time they came into being, especially the governors. But we have seen some enthusiasm in paying these bills. As you stated, the bill is today at 2.7 billion, but it oscillates depending on when the payments are done. Just the other day it was 1.4 billion. And we have seen payments coming in. Today I can mention Nyeri paid 50 million, and other counties have also paid as well.
All right, Valentine, I want to bring you into this conversation as someone who obviously engages with the Mwananchi as part of your daily work. When you hear this conversation about drugs, what comes to your mind? What is really going on from the standpoint? Do you think that people understand this conversation that's happening here?
Well, thank you for this opportunity. I think the local Mwananchi is not really conversant with what is happening on the ground or what is happening at government level. So you'll understand, like, maybe for now there are a bit of changes whereby sometimes when you go to hospital there is availability of medication, but still there is a lot of shortage, because sometimes when there is no medication, the replica of what has been in the previous regime comes back. So they will always be complaining there is not enough medication. Although at least for now, there is medication. When you engage with the local dispensaries, there is the issue of the order sheet from KEMSA. They say that what they order, sometimes KEMSA may not be able to provide. So that also brings a gap when it comes to the medication. And because the Mwananchi does not understand, they will always see like it's just the simple medication that is available in our local dispensaries.
Dr. Abubakar, I can see you're dying to say something about this. I mean, there's an issue that has been raised there about the medicine that is available, that perhaps it is either not enough or there are some shortages, and some people then go buying medicine in different places, and the quality thereof then cannot be guaranteed. What is the perspective that you bring into this as someone who is directly involved in making sure that the Mwananchi of Isiolo gets health services in all dimensions?
Thank you, Joe. This is true. We have been having this challenge of KEMSA supplying drugs, but not supplying 100%. And we understand that, and they do communicate that before. So what we have done currently is that we have engaged mates to fill the gap. So even right now, as we've made orders through KEMSA, we've looked at what they don't have, and we've made the same order to mates. So the incoming order, we expect 100% supply, so that our Wananchi are served with all essential medications.
All right. This is an interesting conversation, and I just quickly want to get some perspectives from the floor before we come here. And Mashirima, I don't know what you're hearing from the floor.
Jo, kuna maswali mengi tu ambayo yako hapa, hasa kuhusiana na kwanza tunaweza kuanza na hilo swali kuhusiana na chanjo ya polio ambayo niliweza kushuhudia leo hii katika eneo la Kipsing. Abdikadir nadhani ndio alikuwa na swali hilo. Unaweza kuelekeza swali lako kwa yule ambaye unataka alijibu.
Okay, naitwa Abdikadir. Mimi mkaji wa Isiolo. Swali langu linaenda hivi. Wakati huu kuna chanjo dhidi ya ugonjwa wa kupoza ambao ni polio. Swali langu ni kuna wale wafugaji wa kuhamahama. Nilikuwa nauliza ni mbinu gani mwafaka ambao serikali ya kaunti ikishirikiana na KEMSA imeweza kufanya kufikia wale wafugaji wa kuhamahama.
Nadhani niongeze tu kwa sababu kuna swala ambalo liliweza kujitokeza wakati ambapo nikizungumza na wananchi, sio tu wakati wa chanjo ya polio. Kuna wenyeji wengi ambao wanahisi kuwa wale ambao wanawafikia ni wasimamizi wa afya ama maafisa wa afya kutoka kwa mashirika yasiyokuwa ya serikali, yani NGO ama mashirika ambayo ni ya kutoka kanisani. Labda hilo swali kama linaweza kujibiwa kwanza.
Okay, so they bring an interesting perspective here, which is about nomadic communities. And we'll start with you, Bwana Governor, about what are those things that you're doing? Because this is a pastoralist county by and large, and there are many people who move from place to place, and that makes it extremely difficult to reach them. What really is going on? There is a specific question of the vaccination, and immunization, but I imagine that applies to all kinds of health services.
Yeah, it's true. I think we have over 60% of our population are nomadic. And this I could answer in two ways how they are being catered for. You will realize that as much as a lot of our communities are nomadic, they have a base. And mostly the children and women and the elderly are usually left in this base, and the younger people move away with the animals. So as much as we talk therefore of nomadic setup, most of the people who require care, elderly, the children for immunization, expectant mothers, are usually around centers. These, they may have to move certain distances to the health facilities, but going round, the people know and they are being taken care of. The other thing is we have now mobile clinic through Beyond Zero. And in partnership with the First Lady and Beyond Zero, they actually do a lot of outreach program immunizing communities that are mobile or communities that are settled but far from health facilities. So there is care being given. There is also, as stated correctly, faith-based organizations which partner either with county or on their own, also provide mobile outreach services. So between these, there is some care even to these people who are moving up and down.
What I'm reading about KEMSA, those places can be quite remote. What happens? Do drugs get there? If so, how?
KEMSA does deliveries to the last mile, regardless of how remote a health facility is. And we use sometimes our own vehicles, and sometimes we do outsource to third-party logistics providers to give us an elastic capacity to the extent that should we want to distribute whatever quantity of commodity to all the counties that go, we are able to do that. But just to add on the vaccines, I want to say that we have been working very closely with the Ministry of Health. We've worked with the unit of vaccines, and we have identified where KEMSA can come in and procure some of the vaccines that are needed by the health facilities. And to give an example, we already have yellow fever vaccine amongst other vaccines.
Valentine, working with communities out there, I have heard it said many times that the issue of making sure health services get to everyone is really not just a question of the county or different government agencies that might be there. Civil society groups, what is that involvement that is going on with civil society groups in terms of making sure that the ends of achieving the right to health, which is enshrined in the Constitution, are actually met?
As civil society, it is our mandate to work with the people and, of course, give them information on the importance of immunization. And in some of our programs, we've been working closely with community health volunteers who are, in most of the cases, they're the ones that are used during the polio campaigns, because they know the local communities, they know the people that they serve, and using the health, the community health volunteers is an easier way to ensure that every child in the community is immunized. However, there are also challenges, because you find if our people sometimes do not understand. You know, sometimes in Isiolo we have a lot of immunizations because of the, sometimes we even have it like 5 times a year. You can find out that right now we're having a polio campaign. 3 months ago we had another polio campaign because of the different strings that come. So if the people are not aware of the different strings, parents sometimes are reluctant to allow their children to have the polio vaccine like once or twice in a year. So we really work hand in hand with the community health volunteers so that we can ensure that the parents understand about the different strains of polio.
So who's supposed to help them understand? Dr. you?
Yes, it's a collective responsibility. We have responsibility. We do educate the public about not just polio, but all health diseases. In this case, in the case of polio, we have a special arrangement adding to what the governor said. We use community health volunteers as well as other volunteers to reach every doorstep. This is like it's like a mini census. This is it's one of those special times where we have to reach every doorstep in those 12 counties that we are doing vaccination this time around, and therefore we know we reach every household, and we actually mark, and there is a way to verify that this house has been reached or not. And so this is a special time where we actually reach people to the farthest point.
All right. We have Mashirima with a few more questions.
Na nikisonga mbele tu kwa maswali mengine, lakini nadhani tutaweza kurejea pale jukwani Jo, ili waweze tu kusisitiza zaidi kuhusiana na kama vile bwana director hapo alikuwa anazungumza, anasema kuwa wanafikia kila mmoja, lakini leo hii nilikuwa katika vijiji mbalimbali ambavyo nilipata kuwa kuna wengine ambao hawafikiwi. Katika hilo swali kuna mmoja ambaye anataka kuuliza swali linalofungamana na hilo. Luke Mutui, uko pande gani? Aha.
Thank you. My name is Luke Mutugi. I'm a nurse. My question is to the Governor and the Director of Health Services. There is this issue of a referral system. I would like to ask how, as the county, or what are the plans the county has to improve the referral system in our county, that is Isiolo, in terms of human resource, equipment, and infrastructure, that is the loans, to improve or to ensure the complications arising from the obstetrics, and especially to our mothers, they are catered for.
Okay, look, raising an interesting. I imagine the referral system means moving from a smaller hospital to the bigger one, all the way up. Let's start with you before your boss perhaps say something, Daktari.
Yes, thank you very much, Luke, for the question. So the issue about referral system is very important, even plugging into UHC. And because of that, the county is undertaking an RRI, Rapid Result Initiative, and improving the referral system was one of them. So what we have done so far is that we have streamlined the structure. We have an office now that deals with referral system and emergency. We have repaired most of our ambulances from a baseline of 1 to now 5 and distributed them strategically. Isiolo is very vast. Of course, that is not enough. But so far, we are working with what we have, and we've placed them strategically, and we have plans to add more ambulances. But the issue of referral goes beyond that. Referral starts from the community level, and that's the other area that we are really looking into improving, so that the linkage between the community and the facility becomes easier. And that's where now the investment about the community healh strategy
I hate to interrupt you, Daktari, but for people to really understand what is not working. So do we have too many people coming to the big hospital in Isiolo? Do we have what is not working in that whole system? Because people are supposed to go to that small hospital. When it doesn't work, you go to the next, if I understand it. So you are referred to some place because there wasn't something you needed here and all of that. So what in that whole thing is not working?
So one is the structure itself. It should be working seamless. So you start from community level, you are referred to a dispensary, which is level 1. And so all minor ailments and simple diseases are supposed to be treated at that level. And if that cannot be sorted, then you go to the next level, which is the health center level, which is a little bit more equipped and can handle slightly more complex diseases. And if that doesn't work, then you are taken higher to a county referral hospital or a level 4 hospital. So a good example is a maternal issue. So because you mentioned about obstetric complications, and when a case is identified to be at risk at one of the farthest corner of Isiolo, then that patient is supposed to be referred to a place where the patient can get a comprehensive service, which means a place where the patient can actually benefit from a cesarean section. In our case, previously, we only have one comprehensive facility, which is the Isiolo County Referral Hospital. But part of complementing the referral system is adding 2 more comprehensive facilities in strategic areas again. One in Garbatula sub-county and another one in Meriti sub-county. So as to reduce the distance. So that instead of coming all the way from the farthest corner, which is Basa to Isiolo, then you are sorted at Marti, which is half the distance.
All right, but Governor, he mentioned ambulances. When we were watching that story, we saw 2 that can't even move for 1 inch.
Mm-hmm.
So one apparently was taken there just a month ago and is grounded. So what would be the explanation for something like that?
Well, I think we are due for new ones now because we've repaired the ones that, when we came actually there was only 1. Now we've tried to repair and put about 5 of them ready. The problem is that because of the distances, because of the vast distances, the breakdowns are very frequent. So I think we are now due to organize, because of this UHC program, to have new ones. But I would like to just add something on the issue of referral. Because referral, in an ideal situation, you need to have people taken care of as lower facilities as possible, so that you only have the ones who actually need to come up. But because of long-standing failure, there is lack of trust. People will, when they fall sick, pick their person to come to Isiolo, whether private, more likely actually private. It's only recently that even the level 5 hospital is being looked at. People just know when they fall sick, they must have their money and they must make the journey to a private facility or Kerua. But now we need to reverse this because, number 1, we have to strengthen our community health service. If we strengthen our community health service, 70% of the cases could actually be handled there. The issues of immunization, issues of antenatal care, all this. Then we have to have regular medicines and a staff at the dispensary. Most of the time, this lack of trust happens because when they come, either the medicine is not there or the staff is not there. And then they go up like that. So what we are trying to do is, therefore, number 1, for UHC to succeed, after taking care of the community health, that's between the last facility and the community, we need to have these 2 components, the medicine and the staff, and if possible, infrastructure later. But the key thing is a staff who is regularly available, and medicine which is regularly available, and then the ambulance that can be able now to take in case. These 3 components are very, very critical, and is the thing now we are working on.
All right, we need to take a break. Before we do that, my colleague Mashirima, take us to that break.
Naam, Jo, kuna maswali mengi ambayo yanakuja hivi sasa, sio tu kutoka humu ndani kwenye ukumbi, bali pia kwenye mtandao wa Twitter. Frederick Kidinji anasema staff promotion for majority staff hasn't been done since 2010. Nadhani hilo ni swali ambalo gavana ataweza kulijibu baadaye. Jiro Boru anasema a lot of PR is a lot of time is spent on PR rather than finding out the issues in the county of Isiolo. Chucks James anasema Oldonyiro ward has no functioning health facility. Gavana, labda utatuambia kama hiyo ni kweli na mipango yako kuhusiana na hilo ni gani. Tupumzike kidogo.